Hello, my name is Brian Jonas. I'm from the University of California, Davis Comprehensive Cancer Center. This presentation is on the initial diagnostic workup of acute myeloid leukemia. AML is a heterogeneous disease, and the median age of diagnosis is around 67. In 2018 in the U.S., there's expected to be 19,500 new cases and 10,600 deaths. AML is characterized by a clonal expansion of immature myeloid cells that leads to clinical sequelae of bleeding, infections, and anemia, as well as high rates of relapse. The pathologic definition of AML is shown here on this slide, and it consists of 20% or more myeloid blasts in the peripheral blood or the bone marrow, or an AML-defining cytogenetic lesion, which includes translocation 1517, translocation 821, inversion 16, or translocation 1616, or presence of a myeloid sarcoma. Some other diseases to consider in the differential diagnosis include other acute leukemias, such as mixed phenotype acute leukemia, myelodysplastic syndrome, or MDS, myeloproliferative neoplasms, or MPNs, and severe B12 folate deficiency, which can mimic erythroleukemia. On this slide, I show the 2016 World Health Organization classification of AML. And you can see that there is a significant amount of heterogeneity, as well as a number of different subtypes, which are genetically defined in many cases, such as on the left column, but can also be related to a background of myelodysplasia-related changes. So that's the AML with myelodysplasia-related changes category. And the formal definition of that is shown at the bottom of the slide, which includes having prior diagnosis of MDS or MPN, having an MDS-related cytogenetic abnormality, having AML with multilineage dysplasia. Note that a prior cytotoxic therapy for an unrelated disease is formally defined as therapy-related myeloid neoplasms. In the cases of AML that don't conform to one of these categories, there's a morphologic description of diagnoses in the AML not otherwise specified category on the right. And then you can see there's also myeloid sarcoma. So the initial diagnostic workup of AML is important to both establish a diagnosis as well as to gather samples that are important for prognostication and treatment. And so formally, one needs to get a complete blood count with differential and smear, as well as a bone marrow aspirate. Usually a bone marrow biopsy is also obtained at the time of the aspirate, but should definitely be obtained in the setting of a dry tap. The CBC and the bone marrow studies should be tested for morphology, which will help determine the blast count. The flow cytometry should be done as well to determine the immunophenotype of the disease and assign lineage. And then also from the initial bone marrow biopsy, we will usually obtain studies that are important for both the characterization of the AML as well as, again, for prognostic purposes, and these include cytogenetics. We will get FISH in some cases, and molecular genetics is universally obtained. So again, one of the key features to establish the diagnosis of AML is morphology, and this is usually obtained from the CBC differential and the bone marrow aspirate. So the gold standard is the enumeration of at least 20% blasts from at least 200 leukocytes on blood smears and 500 nucleated cells on spiculated marrow smears. Note for this, pro-monocytes are blast equivalents, and in addition, dysplasia in each cell line should be noted and quantified, and blast counts from immunohistochemical and flow cytometric studies can be complementary to the morphologic enumeration on a manual differential. Next, immunophenotyping is crucial, as multi-parameter flow cytometry is used to establish myeloid lineage in a diagnosis of AML. And here I've included a table showing the expression of cell surface and cytoplasmic markers that can be important for a diagnosis of AML. Next, cytogenetics, FISH, and molecular studies are also part of the diagnostic workup of AML. Conventional cytogenetics is required. We will get FISH, it's recommended by the guidelines if cytogenetics fail, but it is really often tested routinely in practice. In addition, molecular genetic testing is required. The ELN, European Leukemia Net, recommends NPM1, FLT3, CBP alpha, RUNX1, TP53, and ASXL1. The NCCN guidelines recommend NPM1, FLT3, CBP alpha, IDH1 and 2, TP53, and others. Also, multiplex and next-generation sequencing or NGS-based gene myeloid mutation panels are typically being used and are becoming standard for most clinicians that treat AML. Of course, there are new challenges facing us with the 5 new FDA drug approvals for AML in 2017 and 2018. All are either targeted agents or for subtypes of AML. And currently, conventional cytogenetics and molecular gene mutation panels have relatively long turnaround times, so cytogenetics sometimes taking upwards of 5 to 7 days, and molecular studies sometimes taking upwards of 10 to 14 days, depending on the institution or the laboratory to which the samples are sent. Overall, there is a need for rapid assessment on the order of a few days so that optimal treatment can be decided and initiation not delayed. So, for example, a rapid FISH and molecular mutation panel, which has a number of the abnormalities that are relevant to the new treatments, could possibly be beneficial for patients with AML. In conclusion, the diagnosis of AML requires 20% or more myoblasts in the peripheral blood or bone marrow, with some exceptions. We use morphology for blast enumeration, ideally, and immunophenotyping for myeloid lineage confirmation. Cytogenetic and molecular studies have diagnostic, prognostic, treatment, and measurable or minimal residual disease monitoring implications. And the changing landscape of AML prognostication and treatment presents challenges to the clinician faced with a newly presenting AML patient. I would like to thank the audience for listening to my talk today, and hopefully the talk has increased the knowledge of how we diagnose AML. Thank you.